We are back. We're ready to get started. I hope everybody enjoyed their lunch. We are going to talk now about research on diabetes, and we're very pleased to have with us to lead that discussion Dr. Merlene Staten. She is the Senior Advisor for Diabetes Translational Research in the Division of Diabetes and Endocrinology and Metabolic Diseases at the National Institute of Diabetes and Digestive and Kidney Disorders of the National Institutes of Health. I hope you all wrote that down. You'll be tested on it later. Let me mention that for each of the speakers we have today, I'm giving you a very, very brief introduction with the barest highlights, and that goes for our earlier panel as well. Please take a look in the packet that you got. There are bios for each of those speakers, and you can read and get a much better sense of how expert they really are and what their background and experience is, because I don't want to sell any of them short. Dr. Staten is now running or is responsible for a number of different drug development programs. She has extensive experience in endocrinology, metabolic diseases, clinical research, a number of other areas. So she's a true expert, and we're very pleased to have her ready to talk to us today about research into diabetes, what's happened and what's next. Dr. Staten, thank you.
Hi, everybody. Is this microphone about right? I'm usually loud enough, I don't need it. First of all, I want to beg your gentleness today. I am speaking on behalf of my boss, Dr. Judy Fradkin, who is head of our division of diabetes and endocrinology, who actually manages and oversees all this. She really wishes that she could have been here to speak with you today, and she knows every area in depth. I know some areas in depth and other areas not so much in depth, so please do be gentle with me if it's an area that I have to defer on. How do I get the slides going? That's the next trick. And is this forward and backward? Yep. Okay, just it looks like a fast forward. Anyway, today I am going to talk about NIH, and actually if you want the abbreviations, it's NIDDK, National Institutes of Diabetes, Digestive, and Kidney Diseases of NIH. And if you have NIDDK and NIH, you've got the whole thing. But NIH and NIDDK do focus on research. And what I will be covering today is an overview of the broad spectrum of research that we do to avert, treat, and hopefully eventually cure diabetes. And that research spans from basic research to increase our fundamental knowledge of diabetes and look for insights or clues to potential pathways that could lead to treatments from studying molecular targets and at the very basic level. We also really want to focus on, as has been mentioned, I know by prior speakers, prevention of diabetes. How do we identify those people at the greatest risk for developing diabetes, and what strategies can we do to minimize their risk and prevent or delay the onset of diabetes for individuals? And then once people do develop the diabetes, how do we best treat it, and how do we reduce the risk of and the progression of complications, the retinopathy, the neuropathy, and the nephropathy, the kidney that they get? And eventually, we hope to find cures for both type 1 and type 2 diabetes. And I know that earlier today, you have had type 1 and type 2 explained to you, and I will be going into that a little bit more. First of all, I am here speaking on behalf of the Diabetes, Digestive, and Kidney Institute within NIH. But research in diabetes in NIH it goes across many, many institutes. We have the Autoimmune and Infectious Disease Institute that leads the efforts on autoimmune treatments for type 2 diabetes. We have the Aging and Child Health Institutes that partner with us for diabetes across the aging. And of course, we partner with the Eye Institute, with Heart Lung, and with the Neurology Institute on the complications of diabetes. So it's a collaborative effort where almost all the institutes in NIH participate in the NIH in the research agenda. And in addition, It's more, I'm going to come back to that other slide. It was not in my slide deck. It got stuck in there, but it's more than just NIH-wide. This is actually a strategic plan for diabetes research that is a product of the Diabetes Mellitus Interagency Coordinating Committee, which is actually where we partner with CDC and the other agencies within the government for what are the efforts that are going on in diabetes and what should our future research be. And going back just to that other slide, seeing I skipped over it, the funding within NIH for diabetes research is about $1 billion per year in fiscal year 2010, realizing how big this problem is for America. Now, today, I'm going to really focus on the clinical parts. I am a clinical endocrinologist. I'm a clinical researcher, so I'm going to do an overview of our clinical research efforts in type 2 diabetes, type 1 diabetes, and touch upon complications. As you've heard earlier today, development of type 2 diabetes and dysglycemia, or bad high glucose levels, is a continuum that starts when you have normal glucose levels, you have no evidence of any issues, to when your glucose levels start to rise, but they're not yet diabetic, a condition that we call pre-diabetic. There's 79 million pre-diabetics in America that are at increased risk for developing a type 2 diabetes. And once your glucose levels continue to go up and reach past the thresholds that are considered are sufficient for the diagnosis of diabetes, then that is considered type 2 diabetes. And there are almost 26 million Americans that have diabetes in America. And then once diabetes occurs, depending upon genetic predisposition, glucose control, and how long you've had the diabetes, complications can start to occur. And then, as inevitable for all of us, then there is the final outcome, disability and death. And across this spectrum, from normal glucose to complications of diabetes, NIDDK has research efforts across the entire spectrum. And I will spend a little bit of time on each of those, from prevention to complications. One of our NIDDK's led landmark studies has been talked about probably a little bit earlier today, which is the Diabetes Prevention Programs trial. It was a study in which more than 3,000 people who were at very high risk for the development of type 2 diabetes got randomized to either intensive lifestyle, where they increased activity and controlled their diet to lose weight, to treatment with metformin, or to a placebo group. And the results of that trial showed that if indeed you give someone intensive lifestyle, which is reflected by the blue line on this graph, you can see that significant weight loss was achieved for the first couple of years, that people lost about 7 to 8% of their body weight. And that, unfortunately, you couldn't maintain that over the longer term, that body weight did increase somewhat, but it still remained well below where the placebo group was. And that the metformin group was somewhere in between the two. And what did you get with this amount of weight loss? Well, you can see in the blue line that the cumulative incidence of actually developing overt diabetes was more than 50% reduced in those people who lost about 7% of their body weight in that first year. And that metformin had an effect. It was about a third of reduction compared with placebo. And then, as the trial went on into follow-up later to see what happened to those people after the randomized period was over, you can see that that risk reduction persisted, that a loss of body weight and a change in lifestyle can have a dramatic reduction in diabetes that will persist over many years. So that was actually great news, that change in lifestyle can have a major impact on type 2 diabetes. And equally important is the fact that you had that risk reduction no matter what ethnic group that you were in. And if anything, there was a tendency for the African American, Hispanic, and some of the minority groups to have even bigger benefit from the change in lifestyle. So the DPP clearly showed that if you can achieve a change in lifestyle to a healthier lifestyle, more activity, body weight loss, improved diet, that you can reduce your diabetes risk. So one of the things that we have followed on with after the diabetes prevention program was pilot research studies to try to figure out how do we actually spread that finding? How do we make it happen in the real world? And we have a grant program that funds both pilot studies and full studies to look at what are low-cost interventions that are sustainable once the research team leaves, that can stay in the community, and that are potentially disseminatable. If you do them here, maybe you can disseminate them to another community so that they can get the benefit of how they actually encouraged and motivated people to have lifestyle change. And this grant program has been going on for about 5 years now, 8 years now that I think about it. And it's actually led to some very interesting things. One of them is we had a pilot where we put the DPP program, the program from that big research study that I talked about, out into Ys to see what would happen. Could the Ys implement that research? And in fact, the pilot study, the 2-year small study, showed that weight loss could be achieved in the Y with that program. And in fact, a larger full grant program is ongoing now to see how well that can be disseminated otherwise. And I also know that there is an effort, which I'm sure Dr. Albright talked about, to actually, the results were so encouraging, to actually go ahead and start implementing this in some of the Ys, that we need to do something to encourage body weight loss now. So we see this as a direct offshoot of our research efforts to try to get people to put into reality out in the real world what we know works from the diabetes prevention program. So we talked a little bit about how the benefits of lifestyle, increased activity, better diet, body weight loss in preventing diabetes. What about if you already have diabetes? What kind of impact does that have? And we have another study that's called Look Ahead that went to address that. The Look Ahead study was a large multi-center trial with over 5,000 patients who had type 2 diabetes, who then randomized the people to either lifestyle or to standard treatment to look at what were their outcomes in terms of diabetes. And you can see that the intensive lifestyle, again, with coaches and classes, improved fitness and caused a body weight loss, again, of about 9%, a little bit more. And again, you can see, you can do a little bit more at the beginning, it wanes a little bit, but it doesn't go away. The effort to change your lifestyle will persist and will remain with weight loss. And with this weight loss, we got improved risk factors for heart disease. We had improved glucose, improved blood pressure, and improved lipids.
Diabetes support and education. Can you talk a little bit about some of the specific things? Cooking classes versus, here's how to use your needle better, or what exactly?
Okay, can I come back to that at the very end? And but I'll be happy to field that again in terms of what are the best ways. And do we have all the perfect answers for that? No, but I'll come back to that. Okay, but what we did show here is that lifestyle, as in the previous trial, prevents diabetes, and it will improve the outcome of diabetes. So it's not easy to achieve, but when achieved, it can have a major beneficial impact. Well, the prior trials that I talked about were all in adults, preventing diabetes onset in adults or treating diabetes once it occurs in adults. What about in kids? Type 2 diabetes, when I first got out of medical school, didn't really exist in children. Children develop type 1 diabetes. They got diagnosed usually when they were relatively young. They were completely insulin dependent. They needed insulin injections. But over the past 15 years or so, as obesity has increased in our youth, type 2 diabetes has started to appear at medical clinics. And it's also represented largely in our minority populations, in our African American and Hispanic populations. NIDDK has been very concerned about this new presentation of diabetes in the youth, and has also worked to what can we do to prevent that onset in children, and what can we do to best treat it if it does occur in children. And these are the two trials that I'll be talking about. The Healthy Studies of Prevention trial, and the Today trial is a treatment trial. The Healthy study, the results are done. Healthy was a school-based study that was done to reduce risk factors for type 2 diabetes in children. And that it was done in 42 middle schools across America, and that we really focused on about 5,000 students that were from between the 6th grade to the 8th grade. The schools were selected for being low SES and were more than 50% minority and more than 50% free and reduced lunch. Actually, they were very close to 90% free and reduced lunch. And we made targeted changes in the school food service, in the physical education class, a behavior change curriculum in the class, and messaging all throughout the schools. And this was done 6th grade, 7th grade, and 8th grade. And the goal was to see, could we reduce the number of children that progressed from normal weight to the overweight or obese categories. And interestingly, during the time that this trial was done, both groups, the schools that didn't have the intervention and the schools that had the healthy interventions, both had about a 4% decrease in the amount of overweight. Now, we don't really understand why the control groups had such a big effect, but those are the results that happened. But there was an interesting sub-finding to this study that we looked, our outcome was all the children in the school. How many of them progressed to overweight versus how many didn't. When we only looked at the children who were heavy at the start of the 6th grade, we actually showed that they had a significant greater decrease in those that progressed on to obesity. So in the heavier kids, the intervention did appear to have an effect. Speculation is still occurring as to why we had such big increases. But the one thing that I will say back on healthy before I move on to today is the one aspect of the child's life that we really didn't get to in healthy, we covered the school. We did not cover the family and the home so much, and that may be an answer to part of what we saw here. But that's speculation on my part. Now today is the treatment in type 2 diabetes. In those children who actually present with type 2 diabetes to the endocrinologist, what's the best strategy for treating them? And the Healthy trial recruited 700 youth with type 2 diabetes between 10 and 17 years of age. You can see that what I said before about the type 2 diabetes in youth is really in the minority population, that 41% of the children are Hispanic and 32% are African American. So over 70% of the children are from those two minority categories. And they got randomized to metformin alone, metformin plus a thiazolidinedione, rosiglitazone, or metformin plus intensive lifestyle. The trial is actually completed now, and we will find out if aggressive treatment to put drugs on right away with intensive lifestyle or two drugs combined is better than just metformin alone. And the results will be out either later this year or early next year. So stay tuned.
Did you do anything to change the available food in this population? I know, like East Harlem, there have been efforts to, or is that not the real world?
Yeah, the Today trial was a clinic-based trial. By clinic, I mean in the endocrinologist medical care practices. So they would have received diet counseling. There would have been attempts to meet with the family and improve diet, but it wouldn't have been a community effort to change diet in the community. Now, so I've talked a little bit about prevention and treatment in both, children and adults. One of the questions that comes up is, and it's been discussed before, is that we know obesity is associated with type 2 diabetes. If you're heavier, you're at increased risk for type 2 diabetes. But what really is the connection with that? And one of the things that we found in the bottom of this slide, those little round things, if you can see them there, are fat cells. And you can see that they're surrounded by colors, which actually is something that's also relatively new in the scientific community. Over the last 15 to 20 years, we have learned that fat cells are not just a neutral storage of excess fat that we've eaten, but they're actually very metabolically active and secrete inflammatory hormones that cause inflammation in other parts of the body. So they secrete these molecules. They then go to the muscle, to the pancreatic beta cell that secretes insulin, to the heart and the liver and blood vessels, and actually can impair the functioning of those tissues. And that may be one of the ways in which obesity interacts to cause diabetes. Not all of the ways, but just one of the ways. And a thought occurred to one of our researchers, hey, what if we can decrease inflammation? Maybe we can improve diabetes. And in fact, aspirin decreases inflammation and was actually known from the very old German literature to have an impact on reducing blood sugars. And so one of our researchers came up with an idea, excuse me, of studying a generic drug that's cheap and inexpensive, salsalate, which has anti-inflammatory properties, to see what its impact on type 2 diabetes would be if you could block those inflammatory molecules' impact on peripheral tissues. And these are the results from the pilot trial that was done, that was a dose-ranging trial in preparation for the larger trial. And in this trial, this is blood glucose. And you can see that when the salsalate was given at a dose of 3 to 4 grams, blood sugar was dramatically different from the placebo group, and that in fact there was an impact on reducing glucose. And so this is encouraging, but not definitive. And a longer trial is now ongoing to look at 3.5 grams of salsalate versus placebo to see if the addition of a generic, inexpensive drug to our current regimen can block that inflammation and have an effect on type 2 diabetes. Now, one of the other areas, and this is a new area for NIDDK that we're now starting to focus on, is the good news is over the last 20 years, there have been a big influx in new drugs in America to treat type 2 diabetes. When I first got into medicine, it was insulin and sulfonylureas, and there was nothing else for diabetes. Metformin has come along. The thiazolidinediones have come along. We also now have GLP-1 inhibitors and DP. We have a whole variety of different classes of drugs for type 2 diabetes. And the drug companies have done a very good job in doing the studies to get these drugs available to people. But what hasn't happened is if you have a relatively newly diagnosed diabetic, what medicines should they go on first? A direct comparison head-to-head of the different medicines to see how they work. And this is a new effort that NIDDK is working on now, is designing and planning a trial that would be a comparative head-to-head effectiveness trial of the new medications to find out what works best to control diabetes and to prevent and delay the onset of complications. So that's a new effort, no name, no trial name, but something that we're planning and working on at this point. Now, we haven't forgot genetics. You know, we do know that type 2 diabetes runs in families. And the type 2 diabetes genes consortium has been working to identify patients with type 2 diabetes and what the genetic risk is. And over the last decade, they have really identified a large number of genes that each of them play a small role in increasing the risk for diabetes. And investigators are now working out which genes play a role in what part, and if we can figure out what that really means in terms of maybe clues for new therapies. But one of the things is that this group is now focusing on most of the genetic work that's been done to date has been done in Caucasians. And now the focus has switched to minority populations, including the Asians that were discussed earlier that develop diabetes with much lower body fat, as well as African American and Hispanic, so that we can get genetic risk across populations, not just NARS. So nothing concrete from this research yet, but it will lead to something over the years. Now that kind of covers our breadth on type 2 diabetes, adults, children, prevention, treatment, and maybe new pathways that we can intervene on. What about type 1 diabetes? Type 1 diabetes...
Can I have a question before we move on to type 1? I found interesting that we always talk about a number of causes or related causes, but most of these studies have been done about controlling weight. Is that a way of determining this is the cause number one?
I don't know that that's a way of determining that that's cause number one, but we know that there are probably a variety of pathways that lead to type 2 diabetes. But we also know that obesity is something, increased body fat, especially in the abdominal region, is probably one of the greatest associated factors, and that we know that by intervening on that, we can make an impact. Many of these other pathways are still more speculative and being worked out, and we don't necessarily have ways to target them specifically. And the increased body fat probably impacts diabetes more than through just one pathway, probably through multiple, and we're still working all that out. So it's not that, we know that that's one that we can impact now. Others may be that we can impact in the future. Okay, moving on to type 1 diabetes. Type 1 diabetes, you heard a little bit about it earlier today, and also heard eloquently from the two young women who have had years of experience with type 1 diabetes. But one of the things that has been widely recognized is that the clinical course of type 1 diabetes has dramatically changed over the last 20 years. Again, when I first got into medicine, it was not common to see an older person who'd had type 1 diabetes for a long time and that was in still good shape. And now it's actually, you can see that the number of type 1 diabetics that are living longer with type 1 diabetes and living a higher quality of life has dramatically changed. And one of the reasons for this is, I'm going to go back, I'm not going to show that yet, is the trial that's shown down here in the logos, which I don't have a separate slide for, but what is called the Diabetes Complication and Control Trial. Again, when I first got out of school, most of us thought that lowering blood sugar was probably good, but actually, believe it or not, doctors argued that maybe controlling blood sugar had nothing to do with it. Maybe it was all genetic risk. And the Diabetes and Complication Control Trial, which was a trial led by NIDDK, was a trial in which they took type 1 diabetics and they put them to the standard glucose control of the day, which this was back in the mid-'80s, or to intensive control where they really tried as hard as possible to get their hemoglobin A1C to 7% or lower. And what they showed from that trial was by controlling blood sugar, they dramatically reduced the risk for and progression of complications, both retinopathy and nephropathy, and now cardiovascular disease. So we think that definitive evidence has played a role in this improvement that we see over the years. But it's still a long roll. When you go from a child 18 months to 9 years, or 14 months, it's a lot of years, but even more, look at that. 20,000 finger sticks, 8,000 injections, 450 pump changes. It's a huge impact. And the young women today, I think, maybe very bravely spoke that, that it wasn't that bad. But if you think about what that would do in your life, in your home, if one of your children developed this, it's a huge impact in what it means for the children. So we still want to work to try to improve that. And I have to say that we've been very fortunate that Congress in 1998 started an appropriation, the Special Diabetes Funding Program, to support type 1 diabetes, to try to improve the disease and to go for a cure. And that the program is now renewed up through fiscal year 2013. And this infusion of cash has allowed us to focus on the entire spectrum of disease for type 1 diabetes, from what is the genetic risk, what are the environmental triggers, what can you do to minimize the autoimmune destruction of the pancreas that occurs early in the disease, and then once glucose has started to deteriorate, how can you improve control, and what can you do to get those beta cells functioning better to regenerate and reprogram to improve their function. And I'm going to talk a little bit as I go through these steps about some of the research efforts along each of those. And as you can see, we have supported a wide range of research programs that cover the entire gamut. So what are some of the things that we're looking at in terms of genetic risk and environmental triggers so that maybe we can prevent the onset of the autoimmune destruction? Again, we are looking for genetics. The Type 1 Genetics Consortium has started looking at 2,800 families with 2 or more individuals who have type 1 diabetes, and they have now started to identify more and more genes. And the new initiative is to take the genes that have been associated with increased risk for developing type 1 diabetes and try to figure out the pathway by which they cause that increased risk, the actual biology behind that. So this will be work that will still take a while to get from the genetic marker that we know to what it means in biology with the body. But the other thing that we know is genetic risk can occur We know it from families, but yet, for what reason, one of the twins doesn't develop type 2 diabetes or one of the children in the family doesn't develop it? Why is that? It's suspected that there are environmental triggers, that it takes a genetic risk plus something to cause the disease. And we have a couple of efforts, most notably the TEDdy study, where we're trying to figure out what could be the environmental triggers. Could it be a virus? Could it be something in hygiene, either too much hygiene or maybe not enough hygiene, that could lead to something that maybe could eventually lead to a vaccine against that trigger and potentially a cure? Is it something in our diet? Is it cow's milk versus formula versus cereal grains? And the TEDdy study is collecting blood on newborns every 3 months until they reach 4 years, and then every 6 years until they develop diabetes. And these are newborns born into families with high risk for type 1 diabetes. And they're collecting blood, stool, breast milk, toenail clippings, tap water, everything that they can think of, so that maybe we can identify what is the environmental trigger that's associated with this. And this study has now managed to enroll 8,000 newborns that are now getting this ongoing data collection. And the data will be collected over a period of years. And we already have 1 million biological samples stored for analysis to try to identify the environmental triggers and what's most proximate. But then, if you can't stop it before it starts and the autoimmune destruction of the pancreas has already started, what can we do to prevent the autoimmune destruction? And this is where TrialNet, which is a large clinical trial network, which is focused on collecting type 1 diabetic patients who are willing to participate in trials to have them ready to go when potential new therapies become available, has been established. And TrialNet now is conducting trials both for those subjects who have new onset diabetes. How do you keep the little bit of beta cell that's still working when they get new diabetes working longer and better to prevent having problems with glucose getting worse? And there have been a variety of trials. Some are completed, some are ongoing, some are just enrolling. None of them have been major breakthroughs yet, but the study group is posed and ready for new therapies as they become available to be studied. In addition, TrialNet is focusing on prevention. High in those high children who are at high risk for developing diabetes, how do you prevent the onset? And there are not only a natural history study that's trying to look at what are the things that happen before you develop and what is the progression, but intervention studies to look at if we treat with oral insulin or if we treat with an antibody, can we actually prevent the progression to diabetes? Now, one of the other things I talked about is, besides impacting in the autoimmune phase, what can we do to preserve those beta cells that are still, when people develop type 1 diabetes, this autoimmune attack of the pancreas starts. But when they finally develop high glucose levels and are diagnosed with type 1 diabetes, there's still some functioning beta cells in there. How do we preserve those beta cells and maximize their function so that we can delay the severity of disease as long as possible? And we have several efforts along trying to preserve and improve beta cell function. One of them is actually islet transplant. Let's provide islets as part of a transplantation. And we have a consortium that is trying different strategies of different drugs and interventions that they do with islets to preserve the life of islets once they're given. And the Collaborative Islet Transplant Registry is a registry in which the data from transplanted patients is put into a database so that researchers can access it and come up with new clues for what helps with longevity and better outcomes. We also have a basic research consortium called the Beta Cell Biology Consortium that functions on how do we engender beta cell regeneration, get sick beta cells to start working better and produce more insulin. How do beta cells develop, and how are they programmed to start developing insulin, and what can we learn from those pathways that might help us preserve beta cell function? And is there potential in human stem cells to develop into pancreatic beta cells to be done? And then improving glucose control. The panelists at lunch today talked about glucose pumps. But one of the problems with glucose pumps is it provides the insulin. You have to balance that about what's your blood sugar. Is your blood sugar going up? Is your blood sugar going down? Should the insulin go up? Should the insulin go down? one of the real goals is to come up with a closed loop system in which the glucose levels in the blood are measured and fed to the pump, and mathematical algorithms can control how much insulin is being given so that it can work just like your normal pancreas, but it's a machine talking to your blood sugar and to the insulin pump. That's a goal that we are strongly working towards. And there actually are now some pumps that have automatic shutoffs that are approved in Europe, so that if the blood sugar starts to go down, it senses it, it shuts off. That's not yet available in America because there are concerns about if the insulin stays off too long, will there be a rebound, will the blood sugar go too high? But improving and coming up with close the loop between blood sugar and insulin so that the control of blood sugar can be more automated and more simple so that it's not 8 finger sticks a day adjusting the pump and providing this. And there are a variety of different efforts. But one of the things that the pump and the technology that we have today is better than and will continue to improve is this is a glucose curve from somebody on a pump back in 2000. And you can see that even though we'd like the blood sugar to stay between 100 and 150, that it kind of goes up and down and it goes outside of those 2 green lines. It wasn't that great. We have improved upon that a lot. This is what we can optimally achieve today, that we still have ups and downs, but it's a much tighter range. And the area that is still, I think, of the greatest concern is the 2 lows, because that's the part where people actually lose control, may lose consciousness, may get confused. And those are the ones that we want to prevent, as well as keeping it low enough that we don't have risk of progression. But I think that curve shows you the difference between the two, that we've made progress. We want to completely close the loop and improve it even more. And complications, I want to finish with a success story in complications. I talked about this trial before, that improving glucose control as part of that diabetes complication and control trial where they aim to get diabetics down to hemoglobin A1.7 dramatically reduced the risk for the peripheral complication, eye disease, kidney disease, nerve disease, and heart disease. But we now know that getting glucose control as good as possible is what you want to do, but what other pathways can we work through? And angiogenesis, the generation of new vessels, is an area that has become of interest. All of us, when we damage, cut ourselves, or injure ourselves, develop new blood vessels. They're part of the regeneration and healing that occurs. In tumor cells, generation of new blood vessels actually feeds the tumors, and in cancer, drugs that block the development of new vessels have actually been shown to have some benefit. We know in diabetes that people with diabetes have problems in developing normal vessels, and in fact sometimes can generate abnormal vessels that can lead to complications. And so one of the things that became clear is, okay, if abnormal vessels are a problem in causing diabetes complications, could we leverage some of those therapies that are being used for cancer to try to block the development of those abnormal vessels? And those abnormal vessels cause one major problem for diabetics: blindness, diabetic macular edema. Diabetic macular edema is defined by swelling that occurs around that part of your eye that focuses the eye, that allows you to see. And when there's swelling there, you can't see, you can't focus. And that swelling is caused by abnormal vessels leaking and causing that tissue to swell. So what can we do about those abnormal vessels and the swelling? Well, for the last 20 years, the things we've done is we've zapped those vessels. We've used laser treatment to fry those abnormal vessels so that they can't leak and so that the focal point of your eye doesn't have swelling and that you can focus very clearly. However, a recent clinical trial showed that, yes, the laser therapy works. 30% of the people had improved vision at 2 years, but 20% had worse and 50% were unchanged. So it works, but it maybe isn't as good as we'd like it to be. And so some very smart investigators said, well, let's try these blood vessel growth blockers, vascular endothelial growth factor blockers, that can block the generation of these new vessels and see what impact that has on diabetic retinopathy, on macular edema. And so they randomized patients to either get one of these vessel growth inhibitors or to not get it, either with with prompt laser therapy or delayed laser therapy, because laser therapy is the standard of care. You had to involve that in every arm of the study. And about 700 people with about 850 eyes affected by diabetic retinopathy enrolled in this trial to again get laser therapy either with a angiogenesis blocker or with placebo or a corticosteroid. And here are the results, which I think are really definitive. The y-axis is improvement in visual acuity. So if it goes up, that's better visual acuity. And you can see that both groups that got the angiogenesis inhibitor, whether they got prompt laser therapy or they got delayed laser therapy, had a big improvement in visual acuity. Whereas if they didn't get the angiogenesis inhibitor, they got the more normal 2 points improvement in visual acuity, but not the dramatic improvement. So I think there was a huge difference here between getting the vascular growth inhibitor versus not. And I think this is a great example where basic science, where we learned that part of the role of complications is these abnormal vessels that grow and play a role in decreased visual acuity. A knowledge that cancer was using a vascular growth inhibitor to improve tumors, using an established clinical trial network, the National Eye Institute Clinical Trial Network, led to this trial that has now provided a new treatment to help with diabetic macular edema in diabetes. So just to close with, we do also try to help with translating our results, and that the National Diabetes Education Program, which is a joint program with NIH and CDC, does provide a variety of material available to patients and to providers for how do you treat diabetes and how do you prevent diabetes. And that I also, this slide, and it will go up on the website in a copy of the slides, has the contacts of websites where you can go to get additional information. And in addition, we also have our contact here from our public relations office who gets you to the right expert when you want to do an interview to find the appropriate person for information on diabetes. With that, I'll conclude with our logo.
Thank you very much. We have time for one question. I apologize that we're short on time for this session, and then we will not have a break, so please stay in your seats and we'll move right into our next session.
Can I jump to the one question that was already asked? I'll do it real quickly, and we can just still do one. In terms of what's the right diet and lifestyle, like how do you do that counseling? Well, as you can imagine, humans come in many different varieties. What motivates us different, what we like to do is different. And I think, so I think there is no one blue plate for what works best. What works best is for an individual to work, or in a group, for individuals to find out what motivates them to move more, to eat a healthier diet that contains less fat and can result in weight loss. So there are a variety of strategies. Some work for some people, some don't, and there's no one answer for everybody.
You spoke about using a cancer treatment in diabetes. Are you looking at any other treatments from other autoimmune diseases, like for MS or something like that?
That's not my specific area, so I'm not an expert in it. I'll start with that. But yes, they are constantly on the lookout for therapies that work in different areas that might be translated and be a benefit for that. And that's actually why our partner in the National Institute of Infectious Disease and Autoimmune Diseases plays such a critical role, is because they're up on all the therapies for all the other autoimmune diseases that may play a beneficial role in type 1 diabetes.
I guess what I'm asking is there anything up and coming that you can share with us?
Not that I know of, because I'm not an expert in that area.